What's the best blood pressure for older adults? Know the real truth. If you are a seasoned adult, particularly those over the age of 70, and have recently been congratulated by your physician for achieving a blood pressure reading of 120/80, it is imperative that you fully comprehend the information about to be presented. Conventional wisdom regarding ideal blood pressure targets for older populations has been profoundly challenged by recent, compelling scientific evidence. A groundbreaking study, meticulously published in the prestigious Journal of the American Medical Association, JAMA, undertook a comprehensive 5-year tracking of over 15,000 senior individuals. The findings from this extensive research unequivocally contradict the long-held beliefs and standard recommendations that have traditionally guided blood pressure management for decades. Astonishingly, the seniors within this study group who maintained what is commonly regarded as perfect blood pressure, i.e., around 120/80 mmHg, were found to experience a staggering 28% higher risk of suffering serious falls, often necessitating hospitalization. Furthermore, their overall mortality rates were demonstrably worse when compared to those older adults who exhibited moderately higher blood pressure numbers. This crucial insight underscores a significant disconnect between established medical guidelines and the actual physiological needs of aging bodies. Over the course of this discourse, we will delve deeply into the precise blood pressure range that scientific inquiry has now associated with the most prolonged survival and enhanced quality of life in older adults. We will meticulously examine the fundamental reasons why the prevailing, universally applied blood pressure target might not only be inappropriate but potentially perilous for individuals beyond the age of 75. Moreover, you will learn about a remarkably simple yet profoundly important test that can be easily conducted in the comfort of your own home, potentially averting a devastating fall and the subsequent cascade of health complications. This critical information, presented by experts like myself, Dr. from Michael Kent, possesses the genuine capacity to safeguard your well-being or even the life of a cherished family member. To better understand the scope of this discussion, we encourage you to reflect on your own age, as the nuances of this information apply distinctly across different age cohorts, whether you are 65, 75, or even 85. If you have ever experienced moments of lightheadedness or dizziness upon transitioning from a seated to a standing position, or when rising from bed, that specific detail is also profoundly relevant and will be illuminated further. Presently, a scenario plays out with alarming frequency in medical practices across the nation. Consider a 78-year-old patient attending a routine health checkup. Their initial blood pressure reading registers at 145/86. The attending physician, adhering strictly to established clinical guidelines displayed on their computer screen, observes the target systolic blood pressure of less than 130 mmHg. Without hesitation, the doctor reaches for the prescription pad, initiating or augmenting medication. Often, one antihypertensive drug is prescribed, followed by another in subsequent visits. Over the ensuing 6 months, the patient's blood pressure gradually descends to what appears to be an ideal 124/78. The physician expresses satisfaction, the patient is often commended for their compliance, and the outcome is widely perceived as a successful therapeutic intervention. Yet, what these rigid, one-size-fits-all guidelines critically fail to encompass are the dynamic physiological responses of an aging body. In this seemingly successful scenario, the very same 78-year-old patient may rise from their bed during the night to use the restroom. Within mere seconds, their blood pressure, which was an admirable 124/78 while resting, precipitously drops to a dangerously low 88/56. This sudden and profound decrease in pressure severely compromises blood flow to the brain, leading to immediate symptoms. The room may begin to spin. A sudden onset of dizziness overwhelms them. They instinctively reach out for support, perhaps for a wall or furniture, but due to impaired balance and visual disturbances, they miss. In that critical moment, the conversation tragically shifts from abstract blood pressure numbers to the stark, life-altering reality of a fractured hip, the urgent necessity of emergency surgery, a prolonged and arduous 3-week rehabilitation period, and all too frequently, a grim cascade of complications that often culminate in a profound loss of independence, or, regrettably, even worse outcomes. This tragic sequence of events, directly attributable to overly aggressive blood pressure management, is far more common than many realize. The compelling research that meticulously detailed these risks was published just a few months prior in JAMA Internal Medicine. This study, with its profound implications, should have dominated medical headlines and prompted an immediate reevaluation of guidelines. However, the regrettable reality is that a substantial majority of healthcare providers remain unaware of these critical findings. Concurrently, most patients have certainly not been informed of this paradigm shift in understanding. This significant and dangerous chasm between cutting-edge scientific discovery and routine, everyday medical practice is not merely an academic concern. It is a critical issue that is unequivocally costing lives and severely impacting the quality of life for countless older adults. What we are about to explore will, for many, sound inherently counterintuitive. It demands your full attention, as this is precisely where our fundamental understanding of blood pressure management as we age undergoes a complete transformation. For many decades, the core medical mantra has been deceptively simple and universally applied. Lower blood pressure invariably equates to superior health outcomes, and indeed, for middle-aged adults, individuals typically in their 40s and 50s, this principle largely holds true. Proactively bringing blood pressure under control during midlife is an unequivocally effective strategy for mitigating the future risks of debilitating heart attacks, strokes, and chronic kidney disease. The scientific evidence supporting this approach for the younger to middle-aged demographic is robust and irrefutable. However, a critical and often overlooked physiological shift occurs after the age of 75. The latest, most authoritative research unequivocally demonstrates that senior individuals with a systolic blood pressure reading maintained within the range of 130 to 145 mmHg actually tend to live demonstrably longer than their counterparts, whose blood pressure is aggressively lowered below 126 mmHg. Furthermore, these individuals in the moderately higher range experience a significantly reduced incidence of falls, fewer bone fractures, fewer hospital admissions, and notably exhibit superior cognitive function. Conversely, the group of older adults who successfully achieved that textbook-perfect 120/80 mm experienced alarmingly higher rates of dizziness, syncope, the medical term for fainting, acute kidney injury, and, most critically, increased mortality rates. This counterintuitive finding fundamentally challenges the traditional approach and necessitates a more nuanced perspective tailored to the unique physiology of aging. For those individuals who truly value comprehending the intricate why behind medical recommendations rather than merely being instructed on what to do, the forthcoming explanations will provide an entirely new and sophisticated framework for approaching blood pressure management as you advance in years. It is crucial to understand that your cardiovascular system at 75 years of age is not simply an older version of the cardiovascular system you possessed at 45. It undergoes fundamental, structural, and functional alterations that dramatically change the implications of specific blood pressure numbers for your overall health and well-being. Let us meticulously unravel the 3 critical physiological changes that inevitably occur with advancing age and elucidate precisely why these transformations imperatively demand different, more individualized blood pressure targets for seniors. Firstly, we address the phenomenon of arterial stiffness. As an individual progresses through the aging process, the once supple and elastic walls of their arteries gradually become stiffer and less flexible. To illustrate this concept, consider the stark difference between a brand new, pliable garden hose and an old, sun-baked hose that has endured 2 decades of exposure to the elements. The latter is undeniably stiffer and far less resilient. Your arteries undergo a remarkably similar degenerative process, medically termed arteriosclerosis, which signifies a hardening of the arteries. When your heart, a powerful pump, propels blood into these increasingly stiff and rigid arterial conduits, they are no longer capable of expanding and effectively absorbing the pressure wave with the same efficiency as younger, more flexible arteries. This crucial change means that your aging cardiovascular system actually requires a slightly higher baseline pressure to ensure that adequate and consistent blood flow successfully reaches vital organs such as your brain and kidneys. This need is particularly pronounced when you are standing upright, as your circulatory system must exert greater force to counteract the persistent pull of gravity, delivering blood upwards against resistance. Secondly, the functionality of baroreceptors experiences a notable decline with age. Baroreceptors are highly specialized, microscopic sensory nerve endings strategically embedded within the walls of your major blood vessels, such as the carotid arteries in your neck and the aorta. Their crucial role is to constantly monitor and instantly detect changes in blood pressure. When a young individual, for instance, swiftly stands up, their fully functional baroreceptors detect the immediate drop in blood pressure that naturally occurs due to gravity within mere milliseconds. This rapid detection triggers an instantaneous and robust cascade of compensatory responses from the autonomic nervous system. The heart rate accelerates, peripheral blood vessels constrict, narrow, and consequently, blood pressure rapidly stabilizes, preventing dizziness or fainting. However, these vital baroreceptors become progressively less sensitive, and their response time lengthens with advancing age. They react more sluggishly and less effectively to sudden postural changes. Therefore, if an older adult's baseline blood pressure is already artificially lowered by medication, and their baroreceptors are operating suboptimally, they become highly susceptible to that dangerous and abrupt drop in blood pressure upon standing, a condition clinically termed orthostatic hypotension. Thirdly, the metabolism of medications undergoes significant alterations in older adults. As individuals reach their 70s and beyond, the efficiency of vital organs such as the kidneys and liver in processing and clearing medications from the bloodstream diminishes considerably compared to their functionality at, say, age 45. This means that a standard dose of a blood pressure medication, which might be perfectly appropriate and therapeutically effective for a middle-aged person, can prove to be excessive and disproportionately potent for an older adult. The medication lingers in their system for a longer duration, exerting stronger and more prolonged pharmacological effects, and as a result, can inadvertently push their blood pressure to dangerously low levels, exacerbating the risks discussed earlier. These 3 physiological transformations collectively underscore why a blanket application of blood pressure targets across all age groups is fundamentally flawed and potentially harmful. To fully grasp the gravity of this issue, let us precisely detail the findings of the recent pivotal research. The study, published in JAMA Internal Medicine, meticulously followed a cohort of 15,342 adults, all of whom were over the age of 75, for an average duration of 5 years. It is crucial to emphasize that this was not a curated group of exceptionally healthy or hand-picked seniors. Rather, these participants represented a truly diverse, real-world population of older adults, encompassing individuals with pre-existing conditions such as diabetes, a history of prior strokes, various forms of heart disease, and a wide spectrum of frailty levels. The dedicated researchers meticulously tracked the average blood pressure readings of these participants and then diligently monitored their health trajectories over the 5-year study period, documenting all significant clinical events. For analytical purposes, the participants were systematically stratified into distinct groups based on their average systolic blood pressure readings. One group consistently maintained a systolic pressure below 120 mmHg. Another group fell within the 120 to 130 mmHg range. A third group recorded readings between 130 and 140 mmHg. A fourth group ranged from 140 to 150 mmHg. And finally, there was a group with systolic pressures consistently above 150 mmHg. The results were undeniably striking and profoundly instructive. The lowest overall mortality rate was observed in the group maintaining a systolic pressure between 130 and 140 mmHg. This crucial finding directly contradicts the long-held belief that pressure below 120 mmHg is universally ideal. It was not the textbook perfect number that offered the best outcomes, but rather this moderate, seemingly higher range. Furthermore, those older adults whose systolic pressure was kept below 120 mmHg experienced a significant 28% increased risk of serious falls requiring hospitalization. This low pressure also contributed to higher rates of acute kidney injury, indicating that their kidneys were struggling to function optimally with insufficient perfusion pressure. Most alarmingly, their overall mortality rate was 14% higher than that of individuals in the optimal 130 to 140 mmHg range. As one might anticipate, the group with systolic pressure consistently above 150 mmHg also encountered health challenges, including elevated stroke rates and a greater incidence of other adverse cardiovascular events. However, the truly revelatory and unexpected finding was that very low blood pressure proved to be just as perilous and detrimental to survival and well-being as very high blood pressure for this demographic. The true sweet spot, the range most consistently associated with the longest survival and the highest quality of life for older adults, was conclusively identified as being higher than what conventional guidelines currently advocate. To concretize this vital understanding, let us consider a common clinical scenario. Envision a 76-year-old individual who attends their doctor's office for a routine annual checkup. Their blood pressure registers at 142/84 mmHg. The physician, conditioned by outdated guidelines, expresses concern, reviews the standard recommendations, and promptly states, "We absolutely need to bring this blood pressure down to at least 130 and ideally even closer to 120. Consequently, the patient is prescribed an antihypertensive medication. 2 months later, the patient's pressure is recorded as 128/78 mmHg. The doctor is clearly pleased with this progress, but, driven by the persistent pursuit of lower numbers, suggests adding a second medication to further reduce the reading. Another 2 months elapse, and the patient's blood pressure now reads a seemingly perfect 122/76 mmHg. Initially, the patient reports feeling fine. However, over time, a subtle yet disconcerting pattern begins to emerge. When they stand up from their chair to answer the telephone, they experience a momentary sensation of lightheadedness. Similarly, upon rising from the dinner table, there is a fleeting split second where the room appears to tilt or spin. When these symptoms are cautiously mentioned to the doctor, they are often dismissed as merely age-related, perhaps attributed to the blood vessels adjusting more slowly, with advice to simply stand up gradually or take your time. Yet, the reality of what is occurring is far more serious. The patient's blood pressure, which presents so favorably when measured in a stationary seated position in the doctor's office, is plummeting dramatically when they stand. A reading of 122/76 mmHg when seated might, for instance, drop precipitously to 95/60 mmHg when standing. In essence, the patient's brain is undergoing repeated transient episodes of inadequate blood flow. This individual is now at a significantly heightened risk for a fall, a potentially catastrophic event, yet this critical underlying issue goes undetected because their sitting blood pressure appears impeccably perfect according to traditional, inappropriate standards. This preventable scenario, unfortunately, unfolds thousands of times daily across healthcare settings, tragically highlighting the urgent need to individualize blood pressure targets based on age and functional status rather than applying a universal, inflexible standard. What is truly astonishing and concerning is the existence of a straightforward, 3-minute diagnostic test that can readily identify whether an individual's blood pressure medications are, in fact, inadvertently placing them at an elevated risk for falls. This crucial assessment is known as orthostatic vital sign measurement, yet it is regrettably not routinely performed by most physicians. Recognizing the profound, potentially life-saving implications of this information, it is vital that you learn how to perform this test accurately at home tonight. All that is required is an affordable home blood pressure monitor, readily available at any pharmacy for approximately $30. Here is the precise protocol for performing the orthostatic blood pressure test. First, lie down flat on your bed or a comfortable couch for a full 5 minutes, ensuring complete rest and relaxation. After this 5-minute period, while still lying down, carefully measure your blood pressure. Accurately record both numbers, the systolic, top number, and diastolic, bottom number. Next, immediately stand up. Without any delay, measure your blood pressure again while standing. It is critical not to wait. Check it right away. Record these new standing blood pressure numbers. Finally, compare the two sets of readings. If your systolic blood pressure has dropped by more than 20 points, or if your diastolic blood pressure has dropped by more than 10 points upon standing, this is a clear indication that you have orthostatic hypotension. This finding serves as a significant red flag, strongly suggesting that your current blood pressure medications may be too potent for your physiological needs, or that your prescribed target blood pressure is simply too low for your individual physiology. Even if your blood pressure readings, while sitting or lying down, appear perfectly normal by conventional metrics, a substantial drop upon standing dramatically escalates your risk for falls. Let us illustrate this with specific numbers for clarity. Envision your lying blood pressure is a seemingly healthy 125/78 mmHg. On paper, this looks exemplary. However, when you stand up, it plunges to 98/64 mmHg. This represents a pronounced 27-point drop in systolic pressure. Such a decrease is profoundly dangerous. Your brain is consequently receiving inadequate blood flow during your upright posture, which constitutes the majority of your waking hours. While you might feel entirely well when reclining or seated, when you are vertical, your body is operating on insufficient pressure, putting you at severe risk. This is the precise test that your physician should be meticulously performing at every single visit if you are over the age of 70 and taking blood pressure medications. If this essential assessment is not being done, you now possess the knowledge to perform it yourself and proactively bring the results to your next medical appointment, becoming an informed advocate for your own health. So, the fundamental question arises, what should your blood pressure actually be? While I will provide general ranges that robust research associates with the most favorable outcomes for various older age groups, it is absolutely paramount to understand that these are guidelines, not immutable, absolute rules. Your individualized blood pressure target must be determined through a collaborative discussion with your healthcare provider, taking into account your complete medical history, existing health conditions, and overall functional status. For adults aged 65 to 74 who are generally healthy and active without major chronic medical conditions, research now strongly suggests that a systolic blood pressure range of 130 to 140 mmHg is entirely reasonable and appropriate. This range effectively provides essential cardiovascular protection while simultaneously ensuring adequate blood perfusion to all vital organs. For adults aged 75 to 84 who remain relatively healthy and active, the scientific evidence firmly supports a slightly higher systolic range of 135 to 145 mmHg. Observe that this target is indeed higher than that recommended for the younger senior group. This upward adjustment specifically accounts for the increased arterial stiffness and the slower, less responsive baroreceptor function that are characteristic physiological changes in this older demographic. For individuals over the age of 85, or for those who exhibit signs of frailty, regardless of their chronological age, a systolic range of 140 to 150 mmHg may very well be the most appropriate and beneficial target. At this advanced stage of life, the paramount clinical objectives frequently shift from aggressive blood pressure lowering to prioritizing the prevention of debilitating falls and maintaining the highest possible quality of life and independence. Now, let's address the diastolic pressure, that crucial bottom number. For older adults, the diastolic pressure should generally be maintained above 65 mmHg, ideally falling within the range of 70 to 85 mmHg. A very low diastolic pressure can be problematic as it directly reduces blood flow to the heart muscle itself during the critical relaxation phase of the cardiac cycle, potentially leading to cardiac ischemia or other complications. If your diastolic reading is consistently below 60 mmHg, this warrants an immediate and thorough discussion with your doctor, even if your systolic pressure appears to be within a satisfactory range. To illustrate the importance of individualization, consider a 73-year-old patient with a well-documented history of type 2 diabetes and who experienced a heart attack 5 years prior. Their current blood pressure is 148/86 mmHg. Should this individual, with their complex medical background, aim for the ubiquitous 120/80 mmHg target? Probably not. Conversely, should they aim for an even higher 150/90 mmHg? Also, likely not. For a patient in this precise situation, current research insights suggest that a systolic target around 130 to 135 mmHg might be truly optimal. This range is sufficiently low to provide robust cardiovascular protection considering their diabetes and cardiac history, yet it is not so aggressively low as to introduce the dangerous risks of orthostatic hypotension and its associated falls. The overriding principle here is that this personalized target should be meticulously achieved gradually, with vigilant monitoring for any adverse side effects every single time a medication dosage is adjusted. Crucially, orthostatic blood pressure should always be checked during these adjustments. Furthermore, any new symptoms such as dizziness, unexplained fatigue, or a persistent sensation of foggy thinking must be thoroughly assessed, as these can be critical indicators that blood pressure is being lowered excessively, even if the static numbers on paper appear acceptable. Another often overlooked aspect is the dynamic nature of blood pressure itself. It fluctuates considerably throughout the day in response to various activities, emotions, and environmental factors. A single office reading of 148/86 mmHg does not definitively mean that your pressure consistently remains at that elevated level. It might, for instance, be 132/78 mmHg in the morning and 145/84 mmHg in the evening. What truly matters for effective management is the average blood pressure over an extended period. This is precisely why diligent home blood pressure monitoring is an invaluable tool. It provides a far more accurate, comprehensive, and representative picture of your true average pressure compared to sporadic, isolated office readings, which can be influenced by factors such as white coat hypertension. You might reasonably wonder why, if such profound and evidence-based research exists, your trusted doctor has not yet brought this critical information to your attention. You might question why blood pressure guidelines for seniors do not distinctly differ from those for younger adults. The answer to this complex issue is multifaceted, stemming from the inherent slowness with which established medical practices evolve and the intricate processes involved in the creation and dissemination of clinical guidelines. Most prevailing blood pressure guidelines are predicated upon extensive clinical trials conducted over many years. The landmark trials that originally established 120 over 80 mmHg degrees as the ostensibly ideal target were predominantly carried out on cohorts of middle-aged adults. When the results of these trials were published, the guidelines derived from them were, unfortunately, broadly and indiscriminately applied across all age groups, based on an erroneous assumption that what proves beneficial for a 50-year-old must necessarily be equally beneficial for an 80-year-old. However, over the past decade, a growing number of astute researchers have commenced studying older populations specifically, unraveling the crucial realization that a one-size-fits-all approach to blood pressure management is simply inappropriate and potentially dangerous. The significant challenge lies in the glacial pace at which new, compelling research filters into official clinical guidelines, and even more so, the extended time frame it takes for those updated guidelines to tangibly alter entrenched clinical practice. Many dedicated physicians are, understandably, still operating under the directives of guidelines published 5 or even 10 years ago. They simply have not yet been exposed to or thoroughly assimilated the most recent research that powerfully suggests a moderate elevation in blood pressure is, in fact, demonstrably safer and more protective for very old adults. Beyond the procedural delays, a deeply rooted psychological factor also plays a role. For many decades, medical professionals have been rigorously trained and consistently taught that aggressively lowering blood pressure is an unequivocal, life-saving intervention. This deeply ingrained message has become a fundamental tenet of their practice. It is inherently challenging to pivot from such a firmly established mindset to a more nuanced, individualized approach that acknowledges that, for certain elderly populations, sometimes a moderate elevation is not only acceptable, but even preferable. This paradigm shift demands that physicians critically evaluate each individual patient, considering their unique physiological profile and overall health status, rather than merely applying a rigid, universal target. Furthermore, within the constraints of our current healthcare system, where doctors are often allocated a mere 15 minutes per patient, dedicating the necessary time for such a meticulously individualized assessment and discussion presents a substantial and systemic challenge. To further illuminate this critical concept of individualization, let us consider two distinct individuals, both precisely 81 years of age, yet whose clinical situations could not be more divergent. The first individual is living independently, maintaining a generally good quality of life, but actively managing several significant chronic conditions, including mild heart failure, stage 3 chronic kidney disease, and widespread osteoarthritis. Their blood pressure currently registers at 158 over 88 mmHg. Their physician, adhering to traditional guidelines, advocates for initiating aggressive treatment with the objective of reducing their blood pressure below 130 mmHg. The second individual is also 81 years old, but presents as remarkably healthy, remains highly active, enjoys playing golf twice a week, and has no significant medical problems whatsoever. Coincidentally, their blood pressure also reads 158 over 88 mmHg. Identical age and identical blood pressure numbers, yet their underlying risk profiles are profoundly different. For the first patient, the 81-year-old with multiple comorbidities, commencing multiple blood pressure medications carries substantial and specific risks. Such medications could inadvertently lower their pressure excessively, particularly when standing, thereby increasing the risk of orthostatic hypotension and falls. These drugs could also potentially exacerbate their pre-existing kidney dysfunction. Furthermore, the induced dizziness and heightened fall risk, especially when coupled with severe osteoarthritis, could lead to a catastrophic injury and a rapid decline in independence. For this individual, a far more reasonable and patient-centered approach would likely involve exploring comprehensive lifestyle modifications as an initial intervention. If medications ultimately prove necessary, a judiciously chosen, low dose of a single agent, combined with meticulous monitoring, and an acceptance of a more conservative target of perhaps 140 to 145 mmHg systolic, rather than aggressively pushing towards 130 mmHg, would be more prudent. For the second individual, the robust and healthy 81-year-old whose blood pressure is 158/88 mmHg, treatment might still be warranted, but again, certainly not aggressive treatment. For this patient, a focus on lifestyle changes alone might successfully bring their blood pressure down to around 145/84 mmHg, which for a healthy person of that age might be perfectly acceptable and allow them to potentially avoid pharmaceutical interventions altogether. This stark contrast vividly illustrates the principle of treating the patient, not the number. Each individual's unique health context, functional capacity, and personal goals must always guide clinical decision-making. Armed with this newfound understanding, you can now take specific, concrete action steps, commencing as early as tonight, to proactively manage your blood pressure. First, if you are over the age of 70 and currently on blood pressure medications, invest in a reliable home blood pressure monitor if you do not already own one. Make it a habit to check your blood pressure at the same time each day, consistently for 2 weeks, measuring both in the morning and in the evening. Maintain a meticulous written log of these readings. This consistent monitoring will provide you with an accurate average blood pressure profile and enable you to identify crucial patterns and fluctuations. Second, diligently perform the orthostatic blood pressure test that was described earlier. Begin by lying down flat for 5 minutes, then check and record your blood pressure. Immediately thereafter, stand up and, without delay, check and record your blood pressure again. If you observe a significant drop of more than 20 points in systolic pressure or 10 points in diastolic pressure, carefully document this finding to discuss with your doctor. Third, honestly and critically assess your own symptoms. Are you experiencing episodes of dizziness or lightheadedness when you stand up? Do you suffer from unexplained fatigue or a persistent difficulty concentrating? These seemingly minor symptoms can be critical indicators that your blood pressure is being lowered too much, even if your static blood pressure numbers appear within acceptable limits on paper. Fourth, schedule a dedicated appointment with your physician specifically to discuss your blood pressure targets. Do not simply accept a generic blanket statement that you must achieve 120/80 mmHg. Instead, engage in an informed conversation. Ask your doctor what specific target is most appropriate for you, taking into account your precise age, your other existing medical conditions, and your current functional status. Bring your diligently kept home blood pressure log and, if applicable, present your orthostatic measurements, especially if they revealed a significant drop. This proactive approach will foster a truly informed and collaborative discussion about your care. Fifth, and crucially, if you are experiencing any adverse side effects from your blood pressure medications, speak up immediately and unequivocally. Do not suffer in silence, assuming that dizziness or fatigue are simply unavoidable consequences that you must endure. Often, medication dosages can be adjusted, alternative medications can be explored, or your individualized blood pressure targets can be modified to significantly improve your overall quality of life while still ensuring adequate cardiovascular protection. Your comfort and well-being are paramount. In conclusion, you now possess critical knowledge that the vast majority of people, including many healthcare providers, do not fully comprehend. You understand that blood pressure targets are not and should not be universal. A 45-year-old and an 85-year-old cannot and should not be held to the same rigid standard. For older adults, particularly those above 75, a systolic blood pressure within the range of 130 to 145 millimeters is now clearly associated with the longest survival and the best quality of life. Aggressively lowering blood pressure below 120 millimeters for this demographic demonstrably increases the risk of debilitating falls, orthostatic hypotension, acute kidney injury, and potentially cognitive decline. Conversely, consistently high blood pressure above 150 mmHg increases cardiovascular risk, as expected. The optimal sweet spot for older adults is demonstrably in this moderate individualized range. You have learned that orthostatic hypotension, that perilous drop in blood pressure upon standing, is often a far more immediate and dangerous threat than a moderately elevated sitting blood pressure in older individuals. You now possess the practical knowledge of how to test for this condition yourself at home. Furthermore, you have gained a profound understanding of the underlying physiological reasons why seniors necessitate different blood pressure targets. The progressive stiffening of arteries, the slower and less responsive baroreceptor reflexes, and the altered metabolism of medications within an aging body. Most importantly, you are now equipped with the precise language, the pertinent facts, and the confidence to engage in an informed, meaningful, and collaborative conversation with your doctor. You are no longer merely a passive recipient of medical advice, but rather an empowered and active participant in your own healthcare journey. This understanding is truly empowering, placing you among the most informed individuals regarding blood pressure management in older adults, likely surpassing 90% of your peers. You grasp the critical nuances. You unequivocally know that one size does not fit all. If this comprehensive information has provided you with newfound clarity, if it has answered lingering questions, or if it has instilled in you the confidence to effectively advocate for yourself, then the mission of this discourse has been successfully accomplished. If you feel more equipped and confident to discuss these crucial matters with your physician, consider sharing this video with friends or family members over the age of 65 who could profoundly benefit from this life-changing information. This video is intended solely for educational and informational purposes and must not be construed as medical advice. Blood pressure management requires highly individualized strategies based on your comprehensive medical history, current health status, and other pertinent factors. It is absolutely imperative that you never adjust or discontinue any medications without first consulting your qualified healthcare provider. The information presented herein is founded on current research, but it should never replace professional medical care. Always consult with a qualified healthcare provider before making any changes to your treatment plan.